Okay. So first of all, thank you to APASL for inviting me to give this presentation. I was asked to talk about assessment of treatment candidacy in patients with chronic hepatitis B infection in the COVID-19 pandemic era. So the first slide shows my disclosures, and this is an outline of my talk. I would discuss the goals of hepatitis B treatment, the outcomes in untreated patients, the efficacy and limitations of currently available treatments, the indications for treatment, and the assessment of candidacy for treatment and how we would adapt in the COVID-19 pandemic era. So first, what are the purpose of treatment? Obviously, we want to prevent progression of liver disease to cirrhosis, liver failure, liver cancer, and death. We also want to decrease symptoms and improve the quality of life of our patients. Hepatitis B is associated with stigma, and we would like to be able to remove that, and also decrease infectivity and the risk of transmission. But what happens if we don't treat patients? We all know that there is a risk of progressing from acute to chronic infection, particularly if the infection is acquired in children. And in those with chronic infection, there's a risk of progressing to cirrhosis. But treatment can also reverse that process. And once cirrhosis sets in, there is a risk of liver cancer, liver failure that might lead to liver transplant and death. Hepatitis B, unlike HIV and hepatitis C, patients can have immune control with suppression of virus replication. They can also benefit from treatment, but this is what may happen in the absence of treatment. Now, why is it that some patients progress and others don't? We do not have all the answers, but we know that there are virus factors, host factors, and environmental factors. Older age, men, and perhaps genetics, and now increasingly obesity and concomitant NAFLD may play a role. We know that in patients with chronic hepatitis B, they have impaired immune response, and whether their genetic differences is unclear. We know the virus plays a very important role, and certain genotypes and molecular variants have a higher risk of going on to liver cancer. The last 15 years, we've also known that patients with higher viral load are at increased risk of adverse outcome, as is concomitant infection with HIV, hepatitis C, and Delta. There are also environmental factors such as alcohol, exposure to carcinogens, and some studies also suggest smoking increases the risk of liver cancer. Well, what treatment do we have right now? We have interferons, and we have the oral antivirals. We have not had any new treatment, essentially since 2008, because tenofovir alafenamide is just a new formulation of tenofovir disoproxil fumarate. Nonetheless, the development of oral antiviral in the 1990s was revolutionary for hepatitis B, because these drugs are very potent in suppressing virus replication, and through that reduce liver inflammation and fibrosis, prevent progression to cirrhosis and liver failure, and also decreases the risk of liver cancer. But more importantly, these oral antivirals have demonstrated long-term safety. There are, however, limitations with current treatment. While they suppress the virus, they do not completely eradicate the virus. They certainly do not eradicate the cccDNA or the integrated HBV DNA. There's a very low rate of HBs antigen loss, particularly with the non-A genotypes. And for many patients, long duration of treatment is required because virological and clinical relapse oftentimes occurs when treatment is stopped. And while the risk of liver cancer is decreased, it is not completely eliminated. Thus, a major problem when we manage patients with hepatitis B is to decide whether we would treat a patient now or whether we can afford to monitor the patient and treat later when indicated. So what would be the indications to trigger treatment later on? Well, one, if there's evidence that a hepatitis B virus replication or liver inflammation becomes more active. And two, as we gather more evidence, it may be that our evidence-based guidelines will be revised to lower the threshold to initiate treatment. And this actually has happened in the last 10 years, as we have demonstrated safety of the oral antivirals and with the new antivirals with very minimal, if any, risk of drug resistance. And certainly, if we have more effective treatments that can achieve a cure, we will be making differences in recommendations for when we start treatment. So what do the current guidelines recommend? Well, it is very clear that there is consensus among the guidelines put forward by AASL, APASL, and EASL in terms of when to start treatment in patients with cirrhosis. For both AASL and EASL, once the patients have cirrhosis, whether they're compensated or decompensated, we would recommend treatment regardless of DNA or ALT levels. The APASL guidelines are similar but slightly modified in that for patients with compensated cirrhosis, the recommendation is to start treatment if the virus DNA is more than 2,000 or in patients with decompensated cirrhosis would be regardless of any ALT or HBV DNA. In patients with compensated cirrhosis and elevated ALT, there's also no HBV DNA threshold. So essentially, once the patient has cirrhosis, most patients will be starting on treatment. But majority of the patients who've been diagnosed and under care do not yet have cirrhosis. And this is where deciding when to start treatment is more complicated. For the AASL guidelines, which are very similar to the APASL guidelines, there is a differentiation between antigen positive and antigen negative patients. And that's for antigen positive patients, DNA more than 20,000, ALT more than 2 times, or there's evidence of significant liver disease, either assessed histologically or using non-invasive measures such as transient elastography. For antigen negative patients, a lower threshold for HBV DNA more than 2,000. The APASL has slight modifications in that for patients with DNA of less than 2,000, treatment might also be initiated if there's significant liver disease. Similarly, for the antigen positive patients, for lower HBV DNA level, if this is accompanied by significant liver disease. The EASL guidelines have the lowest threshold for starting treatment, in that they use DNA of more than 2,000 for both antigen positive and antigen negative patients, an ALT of more than upper limit of normal, but this is in the setting of moderate inflammation or fibrosis. Otherwise, the threshold for DNA and ALT are actually higher. Note that the ALT definition for upper limit normal was different for APASL and EASL, that's 40, and for AASL, it's 35 for men and 25 for women. So you can see that the most important thing in deciding treatment candidacy is first, whether the patient has cirrhosis, and secondly, what is the antigen status, DNA, and liver enzymes. And in some patients, some form of assessment of liver disease, such as by histology or transient elastography, because we recognize that ALT does not reflect fibrosis and is a reasonable but not a completely accurate surrogate for inflammation either. So in terms of assessing treatment candidacy, the most important thing is how urgent is it? Do we deal with a potentially life-saving situation? For example, patients with acute liver failure, decompensated cirrhosis, or acute on chronic liver failure, or patients with severe exacerbations of chronic hepatitis. Under these circumstances, the guidelines essentially is based on clinical assessment. Acute liver failure, as we know, is based on evidence of acute liver injury with encephalopathy and coagulopathy. And these patients would be hepatitis B surface antigen positive. Occasionally, they may be surface antigen negative, but should be IgM core positive. While it is important to get a baseline HBV DNA, when we make the diagnosis, treatment may start while waiting for the result. Similarly, in patients with decompensated cirrhosis or acute on chronic liver failure, the diagnosis is mostly clinical. Ascites, encephalopathy, variceal bleeding, multi-organ failure. These patients would be surface antigen positive, and we would also want to get the baseline DNA. But in these urgent patients, treatment may start while waiting for the results. Patients with severe exacerbations of chronic hepatitis B, they would be surface antigen positive. They have elevated liver enzymes, generally speaking, hundreds, occasionally more than 1,000. Severe exacerbation have to be accompanied by increased bilirubin, plus or minus increase in INR, and a hepatitis B virus DNA should be detected. However, it should be recognized that in these urgent situations, the DNA level may actually be low or decreasing at a time when the patients present. Unfortunately, in many instances, we may not have the DNA level prior to the start of treatment. So as I've indicated, the most important thing is to recognize whether the patient has cirrhosis or not. And cirrhosis may be diagnosed either by histology, by imaging, by transient elastography, by lab indices, although these lab indices have better negative predictive value than positive predictive value. Physical exam can be helpful, but usually only in advanced stage cirrhosis. It is also important to assess virus replication through blood tests, liver disease, inflammation, and fibrosis through blood tests, histology, or transient elastography. Now, you know that you don't really necessarily need to have all three of them, and certainly important to have a good clinical history because sex and age of the patient also matters, as is whether there is family history of liver cancer. There are also other indications for hepatitis B treatment. For example, in the setting of the need to prevent reactivation, these are the patients requiring immunosuppressive therapy, where we need to assess the risk of reactivation as well as the underlying replication status and immunity by checking for surface antigen, DNA, core, and surface antibody. The other situation will be prevention of mother-to-child transmission, surface antigen positive pregnant women, where we need to assess for HBV DNA level. And in the setting of patients with hepatocellular carcinoma, to prevent recurrent HCC and liver decompensation, regardless of cirrhosis status, HBV DNA, ALT and treatment modality, suppressing the virus and the accompanying inflammation is beneficial for these patients. So this is what we normally do. Now, do we need to make any adaptations? Because of the COVID pandemic era, there should be very little adaptations necessary because the treatment indications are the same. What is different is that we may not necessarily be able to assess the patients in person because the patients are not able to come to our clinics. But in many countries, we've now resorted to use video or phone visits so that we can still assess the patients even though we're not able to do the physical examination. There's certainly a limitation to our ability to perform some tests. Liver biopsy is obviously severely limited. Radiology and transient elastography is also in many places limited and certainly at the peak of the pandemic. But labs are generally available and the patients do not necessarily need to come to major hospitals. They can go to a local lab because many of these labs are very standardized clinical testing that can be done locally. What is important is there's a greater reliance on clinical acumen, talking to the patients, getting routine labs, and really using our thinking hat to determine for the individual patient whether the benefit to start treatment now outweigh whatever minimal risk that may be. Thank you for your attention.